Welcome to the presentation, Best Practices in Integrative Approach to Optimizing Maternal Well-Being. I'm Dr. Valerie Kading. I'm the Group Chief Executive Officer of Sierra Tucson, and I'm so happy that you can join me for the next hour on this webinar. This webinar is sponsored by Sierra Tucson. You can submit a question on the bottom left of your screen at any point during the presentation. In terms of resources, you can find a PDF of the presentation and additional resources under the headshot image located on the left of your screen. For any help or assistance, please email Melissa Pangaro at naccme.com. And this presentation is eligible to receive credit. You must watch the program all the way through the Q&A section. At the end of the presentation, do not leave the console. Please continue to stay on the platform and you will automatically be redirected to an evaluation landing page. If this is your first time attending a webinar in 2021, you will need to create a NACCME account when you are first directed to the landing page. For all subsequent webinars you attend, you will already have an account and will just need to log in. After completion of the evaluation, you will be able to download or print your certificate. NAADAC credit is only offered for this live broadcast. Thank you. So this picture here is a perfect example of society's portrayal of motherhood. It's summarized with this sentence: a baby will make love stronger, days shorter, nights longer, bankroll smaller, home happier, clothes shabbier, the past forgotten, and the future worth living for. It's a beautiful image of a mom looking into the eyes of her beautiful baby. Now, is this really what happens in motherhood and right after pregnancy? I'd like to say that it is sometimes not an accurate portrayal of what really happens in motherhood and right after pregnancy. And the unspoken truth is that sometimes a mom feels like she's lost herself when she became a mother, that she's tired, that she's overwhelmed, that she feels like perhaps she doesn't have any resources or support, or that she is experiencing herself significant mental health issues. So it's important for us to understand that in the United States, significant amounts of women are having births, and that these women are oftentimes undertreated in this medical system of ours, and that it is important to note that we as healthcare providers play a very important role in how we help mothers, especially after they have their baby and of course while they're pregnant. So in the United States in 2021, the birth rate was about 12 out of 1,000. And we also know that unintended pregnancies comprise of about 45% of all pregnancies. That doesn't mean that these pregnancies are unwanted, but they're just unplanned. And what happens when we're not planning for something? We're oftentimes unprepared. We may be undergoing financial issues. We may be having problems with not having enough support. And so issues like this can really cause increased stressors for a mom and a family when she is struggling in terms of her employment or finances, and then now having to have a baby and an additional member of the family. So when we treat moms who are pregnant, it's important for us to understand that while this pregnancy is one that will bring joy, and that is a welcome pregnancy, it can be a significant amount of times unintended and so unplanned, and that causes some increased stress for the mom and the family. in Arizona, where I reside, we had in 2019 79,000 live births. The reported number of women suffering from postpartum depression was about 13%, which falls in line with what we've historically seen, which is a rate of depression, postpartum depression, ranging between 15% upwards of 20% in some areas. And just in line with the information that we know about unintended pregnancies, in Arizona, it was about 30% back in 2019. What I'm going to do first is review perinatal mood disorders, and these mood disorders occur during pregnancy and also during the postpartum period. So I'll review perinatal depression, postpartum depression, postpartum anxiety, which includes generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and also a more rare form of perinatal mood disorders, which is postpartum psychosis. What's important to note is that these perinatal mood disorders is not baby blues. Baby blues is actually quite common. Up to 80% of women will experience baby blues. It occurs immediately after childbirth, and it's oftentimes transient. So what happens is that a woman will experience it, and then it will not increase in terms of severity, and will typically resolve in a few weeks. So it doesn't linger into 3, 4, 5 months or even up to a year. It's very transient. Depression in women occurs in 2 times greater rate for women than in men. About, again, 10 to 15% of depression can occur during pregnancy and postpartum, and up to 50% of women who suffer from perinatal mood disorders can experience depression during pregnancy. And perinatal mood disorders and postpartum depression really do include symptoms of major depression. So it is categorized as a major depressive disorder with peripartum onset. This is for postpartum depression. It will start typically 2 weeks after childbirth, and again, it does not include the presentation of baby blues, and these symptoms will occur for greater than 2 weeks. A woman must experience at least 5 of the following symptoms. So depressed mood, loss of interest or pleasure, so things that she is typically excited to do or very interested in, she no longer has that feeling about these activities. She could experience significant weight loss or change in appetite. She can have disruption in her sleep cycle, so sleeping too much or not enough. She can have agitation or feelings of fatigue and really not wanting to move or be physically active. She could have loss of energy, feelings of worthlessness or guilt, diminished concentration, and recurrent thoughts of death. The significance of experiencing depression during pregnancy is that these symptoms and how a mom experiences her mood and how she feels really does affect not just her, but also the birth outcomes and how the baby develops. And studies have shown that women who experience depression during pregnancy have had inadequate fetal growth with their baby. There's also evidence that children of moms who've had depression during pregnancy had neurological and language skill issues as they are entering school age years. There's also problems with unhealthy behaviors with the mother, so increased risk of substance use during pregnancy while she's depressed, not attending her OB appointments, and not adhering to activities that would really support her wellness during her pregnancy. There's also concerns with bonding with the baby. If a mom is experiencing postpartum depression, she tends to isolate and have concerns with having eye contact with her baby, holding her baby, the physical bonding, and then also family issues. So women experiencing postpartum depression have a higher rates of marital discourse, potentially divorce, domestic violence. So there is a significant correlation between maternal mental health during pregnancy, post-pregnancy, with, again, the neurological development, the fetal growth, and also the family aspect, and also, of course, bonding with a newborn baby, and also her children that she already has at home. So perinatal depression, again, occurs during pregnancy, and recently Meghan Markle has come out and talked about her experience with perinatal depression. So I got her quotes here, and so she says, I can't be left alone. So she was very afraid of her feelings of depression. She even talked about suicide. She said, I just didn't want to be alive anymore, and that was a very clear and real and frightening constant thought. Chrissy Teigen is a model and celebrity, and she had recently, over the last few years, has also spoken about her experience with postpartum depression. And she says, I had everything I needed to be happy, and yet for much of the last year I felt unhappy. What basically everyone around me but me knew about this up until December was this: I had postpartum depression. So she says she looked at her doctor, my eyes welled up because I was so tired of being in pain, of sleeping on the couch, of waking up through the night, of throwing up, of taking things out on the wrong people, of not enjoying life, of not seeing friends, of not having the energy to take my baby for a stroll. So she was experiencing agitation. She was experiencing sleep disruption. She was experiencing apathy, loss of joy in her life, isolating, and again, low energy. So really the hallmarks of postpartum depression. Postpartum anxiety is another perinatal mood disorder. The incidence is up to 10% of women who are in the postpartum period. And the onset could actually be, again, during the postpartum period, and then also it could occur during pregnancy. And I'll talk a little bit more about the impact of COVID on depression as well as anxiety, and I'll go more into that in another slide in the future here. Generalized anxiety disorder is another form of anxiety disorder that can happen during the perinatal period. It's excessive worrying. The mom will have difficulty controlling the worry, and with mothers, it's typically worry about the safety and well-being of the baby. She must present with at least 3 of the following: so restlessness or feeling edgy, easily fatigued, difficulty concentrating, or mind going blank, irritability, muscle tension, sleep disturbance. It also causes some sort of impairment. So this anxiety is so severe that perhaps she's unable to go to work, or there's impairment with her relationships. So again, the anxiety has to be severe enough where there's some sort of impairment in her life. And of course, that this anxiety and these symptoms are not due to substances. Panic disorder occurs when there's reoccurrent unexpected panic attacks. And so the panic attacks essentially are 4 of these symptoms listed here. So heart palpitations, sweating, trembling, shortness of breath, feelings of choking, chest pain, nausea, dizziness, numbness, feelings of detachment, or oftentimes moms will say, or even just those experiencing panic, they feel like they're actually going crazy, a loss of control, and also a fear of dying. And really, some will even say, I really felt like I was going to die, or that I was having a heart attack. In addition to all these symptoms, the person may also worry of experiencing future panic attacks. So with COVID-19, it's especially been very challenging for women who are pregnant during this pandemic and who have also given birth during this pandemic. As we know, this pandemic has led to quarantine, isolation, mandated work from home, and really created this environment of isolation. And women who were pregnant and had the baby also experienced a loss of rituals because of changes to how hospitals allowed visitors when moms had the baby. So pre-COVID, moms would have the baby, families, friends would come to the hospital, bring flowers. There was a lot of joy around the baby, and this ritual of having everybody come together to essentially celebrate the birth of a child. And with COVID, that has really impacted many moms, where it's the husband or the partner that is in the hospital, and no one else is allowed to visit. Grandparents have had to wait or not seen the newborn for quite some time because of fear of infection. So many women didn't have the same rituals, like including baby showers and other very, very social interactions as they did pre-COVID. So again, isolation has really affected the women, and also the fear of the virus and the safety of herself, and also the safety of newborn, and also the children that she already has at home. So recent studies, researchers have already looked at how has this COVID impacted moms and postpartum depression. What they've seen, research from Brigham and Women's Hospital in Boston surveyed more than 1,100 pregnant and postpartum women between May and August. And what they found is that 36% of women had significant levels of depression. So they were noticing that 36% of women experienced postpartum depression, compared to what we've seen historically, 15 to 20% of women suffering from postpartum depression. Not only that, but what they also found was that more than 1 in 5 women reported significant levels of generalized anxiety disorder, and about 1 in 10 had post-traumatic stress disorder that met the criteria above the clinical threshold. So women experienced a greater rate of, again, anxiety, and also feeling traumatized during this period. Another researcher, Liebel et al., also did a study, and what they also found, very similar results, was that 37% of the women that they surveyed reported clinically relevant symptoms of depression, and that also 57% reported clinically relevant symptoms of anxiety. And what they found was that the higher symptoms of depression and anxiety were associated with more concerns about the threats of COVID-19 to the life of the mom and her baby, as well as concerns about not getting the necessary prenatal care, and also the strain in her relationships and then also the social isolation during the pandemic. So we are already seeing that this pandemic has had significant effects and consequences to the mother and also her interactions and her mental health. So we really, as healthcare providers, need to be aware of this, and that this is going to be an area of concern for the upcoming years, not only for the mom, but again, her offspring and her family. Postpartum OCD generally occurs in about 3 to 5% of moms, and it's comprised of obsessions, compulsions, or both. And obsessions are recurrent, persistent thoughts, attempts to suppress with a thought or an action, which is a compulsion. And compulsions are repetitive behaviors driven by obsessions, and there are also behaviors or mental acts that are done to prevent or reduce anxiety. They're also accompanied by feelings of shame or guilt, and they're ego-dystonic, meaning that a person may have this recurrent, persistent thoughts, and they are very alarmed by it. They don't. They find the recurrent, persistent thoughts is very alarming, and not one that they believe to be appropriate. So this actress, Lisa Rinna, talked a few years ago about her experience with postpartum OCD. And so she said that people don't talk about this. It's very, very scary and vulnerable. I had visions of knives and guns. I made Harry, her husband, hide all the sharp knives and take the gun out of the house because I had visions of killing everybody. So she had these intrusive thoughts, visions of knives and guns. So that was the obsession. And then she was very afraid of these thoughts, these intrusive thoughts. She had her husband hide the knives because she was indeed afraid of these thoughts, which was ego-dystonic. So this is postpartum OCD, and this is different than postpartum psychosis, which I'll talk to you about in a minute here. So again, this is postpartum OCD, and it's important that as healthcare providers, when we do talk with women or their complaints or their presenting issue are having intrusive thoughts or visions, please explore, ask more questions, and find out how she interprets these thoughts, visions, and is this something that she's afraid of, or is this something that she believes to be true, and continue to ask questions and explore. So postpartum psychosis is an emergency. It's extremely rare, so only about 1.2% of postpartum women will experience this, and it's a very high risk for infanticide and suicide. And it's ego-syntonic, and that means that a woman will have psychosis, she'll have delusions or thoughts, and she won't necessarily be alarmed by them. I'll talk about Andrea Yates in a second here, but that's the real differentiator between postpartum psychosis and postpartum OCD. So again, I can't stress enough how important it is that you must ask questions and continue to ask questions and probe about what it is that she's experiencing and what she believes to be true, and how alarmed she is about these thoughts or images or delusions that she may have. So risk factors, history of bipolar disorder, or previous postpartum psychosis. So taking an appropriate history, clinical interview is extremely vital to, again, assessing what's really going on here. So Andrea Yates experienced postpartum psychosis. Andrea Yates was a mom of 4 beautiful children, and she had lived in Houston, Texas, and in 2001, she sadly had taken the lives of her children. And these are her quotes. She says, well, doing it would take them to heaven, and not doing it, there'd be a risk of Satan messing them up. There was the thought about the TVs and cameras in the house, and afraid Satan would ruin my life through himself, and that maybe even that I had some Satan in me. So she had these thoughts, images, and she carried out acts because she believed that that was the right thing to do. She wasn't so alarmed with these thoughts, and so she had taken measures to essentially do things so that she would be in a place where she felt like was appropriate. So this is where, again, you must really ask questions and determine what she's experiencing and how she feels about certain her delusions and hallucinations. And of course, it's a medical emergency. Bring in additional people for assessment if needed, and then it's just, the most critical thing again is making sure that you're asking the right questions and really probing, and having a determination between, is this postpartum depression, postpartum psychosis, or postpartum OCD. So as healthcare providers, it's really important that we understand the importance of ensuring that we limit and reduce the barriers to care for pregnant moms and women in the postpartum period. There's certainly a cultural barrier to care, so certain ethnic groups and backgrounds have views about what's appropriate in terms of sharing mental health issues. I am from an Asian heritage, and no one ever talks about mental health. And so to actually talk about it wouldn't necessarily be welcomed. So ensuring that when you are working with women of various backgrounds to find mechanisms where you can facilitate a mom to be open and to start sharing her experience with you, and being very cognizant of the cultural factor. As we all know, there's a huge stigma for receiving mental health treatment, and I think one of the positive outcomes of COVID is that we've actually started talking about mental health a lot in the last year, and that people seem more open and willing to get help, and the rates of telepsych, teletherapy have increased substantially, and that it is more acceptable, and also it can be done now in the privacy of your own home. So it's good to see some movement in terms of potentially reducing the stigma in the last year, but again, making sure that we are doing all we can to reduce the stigma of a mom receiving mental health treatment. Also, lack of available education and healthcare provider knowledge. So it's historically education regarding postpartum depression, perinatal mood disorders has not been part of the curriculum in nursing school or even medical school. And this is something where we all have to make sure that we are sharing information with colleagues, and also providing and educating each other on what perinatal mood disorders look like, and at the very minimum, in various arenas, that we are having these dialogues with other professionals outside of the mental health field and talking about how mental health really does affect the mom. And I'm glad to see that there's already been studies being done during the COVID pandemic, because this is, again, going to be something that's going to be significant and one hopefully with additional research in the future. Also, liability concerns, I think, especially for those who prescribe medications for women who are pregnant, there's also a fear of being liable if there's some sort of malformation or issue with the baby if one prescribes a medication to a mom while she's pregnant. So we really need to look at these barriers to care and ensure that we're educating each other and healthcare professionals so that we reduce these barriers of care. So moving on to clinical interview, we want to make sure that when we meet a mom, pregnant woman, that we're asking, obviously, presenting symptoms. So when did you start having your symptoms? How long have they occurred? And if there are any precipitating factors. So remember, baby blues happen pretty much immediately or right after birth, and they don't last for months at a time or years at a time. So you'll be able to really distinguish, is this baby blues or really something more serious? You want to look at psychiatric history. Again, women who've had a history of mental health issues are more likely to have mental health issues during pregnancy and postpartum. Any medical histories, you want to really rule out any sort of thyroid issue or any other medical history that may present as depression or other psychiatric conditions. And evaluating family history. So if a mom has had a mother who's had a history of postpartum depression or depression, again, they're more likely to have a mental health issue. So looking at all these histories, we also want to look at what medication or treatment she's on. Is she breastfeeding or planning on breastfeeding? And these are for our healthcare professionals who are prescribing medication. There's certain medications that are more favorable to use if someone is planning on breastfeeding or not. You want to look at the half-life of the medication and, of course, whether or not she's stable currently. Those are all things that you want to look at when talking about medications, because the last thing we want to do is to destabilize the mom while she's pregnant. Looking at family and social support, that's very important, as we know that the less support that a mom has, the more detrimental it is for her, and that enlisting the help of the family and social network is vital during pregnancy and postpartum. Looking at her career, what does she do, and how is this pregnancy going to affect her career, and what's her plans for after she has the baby, because those, again, will impact either the support that she's going to need and the kind of interventions that she may be willing to engage in. Assessing for adverse childhood experiences, so ACEs, and I'll talk a little bit more about that in the next slide. And then, of course, evaluating for substance use. Is she drinking any sort of alcohol, or has she before she found out she was pregnant? Is she using marijuana? Many states have now opened up marijuana for recreational use and even medical use, and so has she been using those substances? And that will lead to, of course, conversations about using substances during pregnancy and afterwards, and also the effect of the unborn child or until up to when she stopped using during the pregnancy. So adverse childhood experiences includes abuse during childhood, any sort of neglect. There was a family member or someone living in the household with mental illness, substance use in the home, parental divorce or separation, or anyone in the household that was incarcerated. So there was a huge ACE landmark study, which comprised of 17,000 individuals, and it was a partnership between Kaiser and CDC. And what they found when they evaluated patients the patients received medical care at Kaiser, and then the researchers contacted those individuals and asked them, have you been a victim of physical abuse, sexual abuse? Have anyone in your family use substances, anyone in the household, or anyone incarcerated, or experienced divorce? So they asked them these questions. And what they found was that about 30% of the individuals in this study said they've experienced physical abuse. About 21% said they've experienced sexual abuse, and this is all before the age of 18. And that 40% of this population experienced 2 or more ACEs, so adverse childhood experiences. That's a pretty significant amount. And what they also found was that the more adverse childhood experiences one reported, the greater risk they had for health problems later in their life, and also risk for substance use, for depression, for suicide, for sleep disorders. So the trauma that's experienced before the age of 18 has impacted physical, medical, and mental health issues in life. And that experiencing 4 or more of ACEs has had a dramatic increase in the risk of these negative consequences in life. So this study was very significant because it essentially says that the trauma that you've had in childhood impacts your life. It impacts not just your mental health issues, but also your physical issues, and that you could be at greater risk for heart disease, for early death, for heart attacks, for diabetes. And so this really, again, is something that assessing a mom for is important, because once you determine the ACE score and her history of trauma, you're better able to tailor the treatment to include trauma treatment. Also want to share the EPDS, which is a screening tool that can be used during pregnancy or postpartum. It's 10 questions, and they're all weighted differently. And a score of 13 or more is essentially a positive score for depression. So it's a validated tool that's used commonly. It's not used enough. It really should be a tool that's used for all women. And I think in the last 10 years, there's been great strides of implementation of this in OB clinics and PEDS clinics. And so it's a very simple tool to use, and one that you can, again, have the mom score herself, and then you can have a nice conversation about what her score is, and of course, if it's 13 or more. So in terms of recommendations from the Postpartum Support International, the recommendation is you want to do the EPDS at the first prenatal visit. You want to do it at least once during the second trimester, and then complete it at least once in the third trimester, 6 weeks postpartum OB visit, and then 6 and 12 months at the postpartum period, OB or PCP, and then 3, 9, 12 months at the PEDS visit. So these are the recommendations from PSI. ACOG also recommends that this EPDS is done once during pregnancy and once during the postpartum period. In terms of treating women, it's very critical that this is done in a very integrative approach. So what does that mean? It means that we want to make sure that we are looking at her situation as one of, we want to make sure that we want her to be the at her best level of functioning. We want to look at this as, how do we get her to become the healthiest possible person, and look at it from a health standpoint versus as a disease. And so while we do have to diagnose and use the DSM and have all of that, really want to be using an approach where this is one of wellness. We want to look at her as a whole individual person and not as a diagnosis, and that the relationship between the healthcare provider and the patient is very critical and central to how we are going to work with these moms. The integrative care model looks at the biological aspect, social, psychological, and spiritual dimensions of the woman. So being able to identify these and seeing how you can make an impact on this, and understanding what all these mean to her and how important it is for her in terms of what sort of support she needs in these aspects. The integrative team can be comprised of a therapist, psychiatric provider, OB, GYN, internal medicine, pharmacist, naturopathic medicine, provider, and those have, I've had the pleasure of having colleagues who are NMDs, and they've been, I think, specially trained to work with women who are pregnant and postpartum, and have been very much so a very vital part of the team, and of course the mother and the partner. So in terms of interventions, individual CBT has been shown to reduce depressive symptoms. It's used to prevent postpartum depression, and treatment during the postpartum period is more effective than antenatal. So it's also been shown to be better than group therapy. Family therapy is also critical in terms of ensuring that there's adequate support for the mom, and being able to understand how this new baby is being integrated into the family and what that means for the family dynamics. And then trauma-focused care, again, evaluating the ACEs and being able to address that through the trauma lens. There's also naturopathic therapies that have been studied. So St. John's wort is an herb, and it's been shown to be effective in mild to moderate depression, although several studies show the effectiveness, and then there's also some that aren't necessarily showing robust results, so very mixed results. Safety can remain a question mark in terms of the rigorous nature of evaluating the authenticity of these herbs. And then there's also drug-drug interactions that may be of concern if a mom is also on an antidepressant. Acupuncture has also been shown to be effective in studies. So symptom reduction with acupuncture in an 8-week trial. Side effects could include insomnia, fatigue, and anxiety. The one thing to be careful of with acupuncture during pregnancy is that it has been shown to sometimes to show uterine stimulation. Bright light therapy can also be effective in treating depression. What's good about bright light therapy is not a medication that you ingest. It's bright light therapy, and that studies have shown that there's been significant reduction in 3 or weeks of therapy. And then, of course, exercise. ACOG recommends 20 to 30 minutes of exercise, and that certainly can be very effective in terms of energy level and mood. Yoga has also been shown to improve depression and anxiety scores, and that, again, is non-invasive. It's something that will help a mom with depression, anxiety. And then transcranial magnetic stimulation. It is a non-invasive procedure. This is the chair right here and the apparatus. It's mixed pulses to the brain, and it goes to the left dorsolateral prefrontal cortex. There have been 6 studies that have shown a decrease in depressive symptoms in moms who are pregnant or pregnant moms. So again, this looks very promising, and again, it's non-invasive. Sleep hygiene is extremely important. So reminding mom, don't use electronics before going to bed. Avoid stimulants like coffee, sugary drinks, using the bed for sleep and sex only, and not, again, on your computer or on your phone. Creating an environment conducive for sleep, and then having some sort of pre-bed ritual that will help a mom get to sleep better. So maybe even some herbal tea that can help her get to bed better. So medications are certainly an option for a mom who is really suffering from depression or anxiety, bipolar disorder, obviously psychosis. And what you want to do as a healthcare provider prescribing medications is really talk about benefits versus risks of the medications. I, as a psychiatric nurse practitioner treating women who are pregnant and postpartum, I spent a lot of time talking with the mom about what the benefits were of medications and what the risks could be to herself and her baby, and what are also the risks for untreated depression and anxiety during pregnancy, because earlier in this presentation we did talk about the risks of untreated mental health issues in a mom. So having that discussion, and then of course making sure that it's individualized. So it's an approach where you're talking with her about what it means to her to be taking medications, and as an expert, you providing the knowledge and literature and resources to be able to make that decision with her. And in terms of medications, there's no such thing as completely safe. There is literature from the manufacturer and studies that will show any information about certain medications used in pregnancy, and so it's best if you're prescribing medications to be aware of all of that. There's always new studies coming out about medications used during pregnancy. You want to use the lowest dose possible, obviously documenting your conversations and resources that you use to make a decision with the mom. And then communication, education is vital to your relationship with the mom if you're prescribing medications. So addressing unique needs, we want to make sure that there's alliance with the healthcare provider, so alliance with the mom and you and other people on the treatment team, ensuring that there's family support for the mom when she goes home, that the partner is there to support her, and if there's anyone else that could help with nighttime feedings or issues that happen in the night, babysitting, and then of course ensuring that there's an integrative approach to treating the mom, and that it's not a one-dimensional approach to treating her. Of course, if you're working with women, you always want to ask if she's planning a pregnancy, and even if you don't particularly just work with women, or if you're not working OB, anyone working in psychiatry should always ask about pregnancy and plans for pregnancy. Mom knows that she's pregnant. Make sure that there's a prenatal vitamin. It's so easy to get those. Planning for prenatal and postpartum care, obviously avoiding substances and alcohol. And so ensuring that she's getting support for that and appropriate referrals. So for healthcare providers, these are a list of resources for you. So Postpartum Support International is a really worldwide organization that is there to help healthcare providers and also women. The Mass General Center for Women's Mental Health is another great resource, and there's a website, Hale's Medication and Mother's Milk. So all the information you may need about prescribing medications to pregnant moms and those who are breastfeeding. And then here are two screenshots of LactaMed. It's an app that you could use from the NIH, and then Hale's Medications and Mother's Milk. They're free resources, and you can just download those, and it's easy to just search a medication, and it'll give you all the information that's available for certain medications. So as healthcare providers, you can make a difference. Please continue to gain as much knowledge as you can about how to better help women, women who are pregnant, women who are in the postpartum period, getting education, ensuring that you're receiving support from your colleagues and helping these moms, and then being able to refer to appropriate specialty groups as needed for these moms as they continue their journey into motherhood. So that may obviously include therapists, psychiatric providers, peds, OB, so ensuring that you have a nice team of other healthcare professionals to help support the mom. So I'll quickly go over case studies that I presented here. There's 2 case studies, and these are actually women that I've worked with in the past. This first case study is a 22-year-old married Hispanic female reporting intrusive visual images of her baby in a microwave. So this mom comes to treatment, and this was one of her initial presenting complaints and reports, and further exploration of her psychiatric history. As a child, first of all, she was an only child. She was a perfectionist, which didn't surprise me because when I saw her in my office, she always looked, there was not one hair out of place. She always had a very coordinated outfit on, and I could tell that she was a very type A personality, and so she indeed did share that as a child she was the same way too. And she also had a history of anxiety, and so what diagnosed her with was postpartum OCD, and we addressed the postpartum OCD with therapy. She had intensive therapy, and also gave her an SSRI to address the OCD, which resolved. She got better at about 6 months. But what I wanted to point out too is these intrusive visual images were ego dystonic. She was alarmed by them. She didn't think she was going to hurt her baby, and that was the most frightening thing for her, was that she was going to harm her baby. And so she, again, did not want to harm her baby. These intrusive thoughts were very alarming, ego dystonic, and again, diagnosis of postpartum OCD. Next case study is a 29-year-old married nurse presents to appointment with husband who's holding the 6-week-old baby. And that was the first thing I noticed, was that she came in, she wasn't holding the baby, husband was. Husband was very attentive, very supportive. During my appointment with her, she had no eye contact with the baby. She had a very flat affect, and did not have a history of any mental health issues. And her depression was, again, was ongoing. She had the 6-week-old baby. I knew it wasn't baby blues because, again, her baby was 6 weeks old, and that her presentation really was a postpartum depression. And upon further exploration, she had low energy. She was sleeping all the time. She really was not interested in things that had made her very happy before. She didn't have any thoughts of self-harm, but again, her depression was so profound. So she was treated with intensive therapy and also an antidepressant. So that concludes the presentation. We are out of time. I encourage you to send any questions you may have. My email address is on the screen at valerie.kading@sierratucson.com. And thank you so much for joining me on this webinar.